All right, if you are getting ready for the NCLEX, you know that fluid and electrolyte questions are a huge deal. So today, we're going to crack the code on one of the trickiest ones out there, hyponatremia. I promise, by the time we're done here, you are going to feel so much more confident about this. Let's jump right in. Okay, let's start with the number one most important rule you need for the NCLEX. Seriously, if you only remember one thing from this entire explainer, make it this. Hyponatremia is not really a sodium problem. It's a water problem. It's all about having too much water diluting the sodium that's already in the body. Getting this one concept down is the key that unlocks pretty much every single question you're going to see on this. So, if the main issue is just too much water, how does that actually translate to the numbers we see on a patient's lab results? Let's get into the official definition. So officially, hyponatremia is diagnosed when that serum sodium level dips below 135. But you have to keep our main rule in your head. This number doesn't mean the patient lost salt. It means the water to sodium ratio is way off balance. And as we're about to see, the lower this number drops, the more dangerous things get for our patient. I want you to pay very close attention to this number, 120. When a patient's sodium gets this low, or even lower, we are in a full-blown emergency. This is the line in the sand for severe hyponatremia, and it's where we start seeing those really scary, life-threatening neurological symptoms. This isn't just a lab value anymore. It's a 5-alarm fire. Knowing the what is great, but the NCLEX is all about testing if you understand the why. You have to figure out the root cause of the problem, because that is what's going to dictate your entire nursing plan of care. Okay, so the causes really fall into two main buckets. The one you'll see tested most often is water excess, where the body is just holding on to way too much water. So think about conditions like SIADH, heart failure, or maybe even a patient who's just getting too much D5W through their IV. The other bucket is actual sodium loss, from things like diuretics, really bad vomiting, or diarrhea. Just remember, while both can happen, the NCLEX absolutely loves to test you on those water excess scenarios. So what happens with all that extra water in the bloodstream? Well, it's basic osmosis, right? Water follows salt. So when the bloodstream gets all watery and diluted, the body's cells are suddenly much saltier in comparison. And what does the water do? It rushes out of the bloodstream and into the cells, causing them to swell up like little water balloons. And this is where hyponatremia becomes so incredibly dangerous. A muscle cell in your arm can swell up, and it's no big deal. But a brain cell? It's trapped inside a bony skull. So when those brain cells swell, they have absolutely nowhere to go. This leads to a dangerous spike in intracranial pressure, and that is the direct cause of all the major neurologic symptoms we see. It's a critical chain of events. Low sodium leads to cellular swelling, which leads to brain swelling. So what does this swelling brain actually look like in a real patient? This is what you, as the nurse, need to be able to spot at the bedside, hopefully catching it before it turns into a total catastrophe. Okay, listen up, because this slide right here is NCLEX gold. The priority signs and symptoms of hyponatremia are all neurologic. It can start out pretty subtle, maybe just a headache or some new confusion in an older patient, but it can quickly get worse, progressing to lethargy, a decreased level of consciousness, and then ultimately seizures or even a coma. I really cannot say this enough. When you see a patient with hyponatremia who has any kind of change in their neurostatus, that patient is your absolute number one priority, period. This is the most dangerous sign of the condition, and it demands your immediate attention. Now, of course, there are other symptoms. The sodium imbalance can definitely affect the muscles, causing cramps and weakness. It can also mess with the GI tract, leading to things like nausea and vomiting. These are important to notice, for sure, but they are always secondary to those life-threatening changes happening in the brain. Okay, so you've assessed your patient, you've identified the problem. Now, what are you going to do about it? Let's get into the plan of care, covering both what the doctor will order and what you'll be doing as the nurse. For the NCLEX, the order you do things in is absolutely critical. So for most cases of hyponatremia that are from water access, the first-line treatment is simple, fluid restriction. If the problem is too much water, we stop putting more water in. Now, if the patient has those severe neurosymptoms we just talked about, like they're having a seizure, that's when we might escalate to step 2, very carefully giving Hypertonic 3% saline. And of course, we always have to treat whatever caused this mess in the first place. Okay, I need you to really focus here for a second. This is one of the biggest safety traps on the entire NCLEX. If you correct that sodium level too fast with hypertonic saline, you can cause a catastrophic and, listen to this, irreversible brain injury called osmotic demyelination syndrome. I'm going to say it again, irreversible. The only safe way to do this is slow and controlled. So what are your top priorities at the bedside? Number one, you are the eyes and ears for any neurological changes, so frequent and detailed neurochecks are completely non-negotiable. For any patient who is at risk, you need to get seizure precautions in place. And then you're going to become obsessed with their fluid status. That means strict I&Os, daily weights, and constantly keeping an eye on those follow-up lab results.
Okay, we've covered the core science. Now let's switch gears into pure NCLEX strategy. We're going to lock this knowledge in with a few easy memory anchors, and I'm going to point out the common traps the exam will try to set for you.
You know what's super easy to confuse? Hyponatremia and its opposite, hypernatremia. This little chart makes it simple. Hyponatremia is a water excess that causes a swollen brain. Hypernatremia is a water deficit that causes a shrunken brain. And while both of them can cause confusion and seizures, the underlying fluid problem is the complete opposite. Here are 3 super simple phrases that can be your mental flashcards on exam day. First, low NA equals swollen brain. That connects the lab value to the biggest danger. Second, restrict water first. This reminds you of the priority intervention. And third, 3% saline equals ICU level care. That should remind you that this is a high alert medication for only the most critical patients.
And finally, you have to know the enemy. These are the classic tricks the NCLEX loves to use. They'll tempt you to give hypotonic fluids like D5W, which would literally be like pouring gasoline on a fire. They'll test to see if you remember the danger of correcting the sodium too fast. And they'll give you a patient with just mild confusion to see if you're sharp enough to make it a priority. Be ready for these.
Wow, we have covered a ton of ground. Now it's time to put it all together and use our clinical judgment, just like you're going to have to on the next-gen NCLEX. Okay, here's the scenario. You have a 78-year-old patient with SIADH, so we know why they have hyponatremia. Their sodium is 121, so it's in that severe range. You walk into the room and you find them confused and actively picking at their IV line. They are clearly not oriented and they are not safe. So what do you do first? What's your priority action? Do you call the doctor? Do you start restricting fluids? Do you grab some saline? Your first, most immediate action has to be ensuring patient safety. With that confusion and agitation, this patient is a huge risk for falling or pulling out their IV. So your priority action is to implement safety measures, like maybe one-on-one observation, while you prepare to notify the provider about that change in neurostatus. That right there is clinical judgment in action. Safety first, then treatment. If you can master that way of thinking, you'll be ready for anything the NCLEX Thursday